A very
Morning, sir.
good morning.
Good morning. Good morning.
Good morning, sir.
Good morning. Good morning, sir.
So, good morning to all. It's a lovely day to be together and explore the part and parcel of our lives, the dentistry. Academic institutions basically they pave way for individuals to become professionals. And it's the professional associations that keep the professionals going by, updating and guiding them in their career. If both of these come together, the professionals continue to be updated and flourish in their profession. I am Dr. Anil Kumar. On behalf of the organizing committee, I would like to extend a warm welcome to all present here for the first webinar jointly hosted by IPS Karnataka State Branch and JSS. It is indeed my honor to welcome our esteemed guest of the day, Dr. J.R. Patel, President, IPS, Dr. Rupesh, Secretary, IPS, Dr. Sanat Shetty, President, IPS Karnataka State Branch, Dr. Sunil, Secretary, IPS Karnataka State Branch. The panelist, Dr. Sudhindra, and the speaker, Dr. Mahidhar. Of course, I also welcome all the registered delegates. Thank you to each one of you for being with us today. As part of our motivation in imparting the knowledge, it doesn't end today, but it is going like a series of webinars in the future. May I request all the delegates to please note that they can communicate using the chat box. All the questions will be addressed by the speaker and the panelist at the end. All the registered delegates will get a digital certificate in the mail, and everyone is requested to provide us the feedback to enable us to improve ourselves. May I now request Dr. Rupesh to take over and introduce the president of IPS.
Thank you, Dr. Anil. There's dignitaries online, and the people who are offline, we don't bother much. So let me bring you greetings to each and every one of you from the Indian Prosthodontic Society head office and all the executive council members for the IPS. Friends, there is a saying which says that people who are not willing to learn, no one can help them. But someone who's determined to learn, nobody can stop them. So I'm sure these webinar series which are on the run, which we see now, is a new norm for learning. And I'm sure people who are determined to learn will make the best use of these webinar options, which most of us does of late. And let me also compliment the IPS Karnataka State Branch for kickstarting their webinar series today. And my sincere thanks to JSS Academy of Higher Education for providing all the support so that we see the light of the day of this particular event. From the IPS head office, we are also very grateful that most of our state branches have been running the webinar series for a long. Most of the branches have initiated this process, so I'm sure it's a win-win situation for most of our young, dynamic graduates, postgraduates, and even the faculty and practitioners. Listening to amazing speakers which these branches have organized. And today, it's indeed a happy moment. We have the young and dynamic speaker, Dr. Surbi Mahidhar, who is with you. And it is more heartening to know that he's an alumnus from your academy, from the JSS. So that is a double whammy for your institute as well as the Karnataka State Branch. So thank you, Mahidhar,
thank you, sir. Thank you.
for being here. Now let me go to my task of introducing our chief guest for the day. It gives me great pleasure to introduce the chief guest for the function today, who's here to inaugurate this webinar series by the IPS Karnataka State Branch. It's none other than the very renowned academician and above all the president of Indian Prosthodontic Society, Dr. J.R. Patel. Friends, Dr. J.R. Patel did his undergraduation. He's completed his BDS way back in the year 1981. And the year India won the World Cup, yesterday another Mahi retired. We have another Mahi, who's going to talk to you today. Another one of our World Cup winning captains retired, and it'll be interesting to note that Patel sir completed his MDS in the year 1983 when India won the first World Cup. So that is like about 38 or 39 years back. Even though when you look at him, he looks probably not. Yeah, thank you, Sanath. I'll note down that number. Yeah.
17.
Thank you, Sanath. Right. So Patel sir don't look not a day older than 38. What I was just trying to tell you. His PG and UG were both from the GDC Ahmedabad, and among the various posts which Patel sir has held, he started his career, I think, as a professor and head at the Balaji Dental College in Chennai. Somebody from Ahmedabad, and Patel sir has been a professor and head in Chennai. See, many a times, when we have interacted with Patel sir for conferences, I see him straight away go to the idli and dosa counters. So I used to wonder, instead of the dokla and and tapla, which he prefers, what is his affinity to dosa and idli? So that is the secret. He was initiated to the dosa idli culture in Chennai as the professor and head in Balaji Dental College. And later he became the principal, dean and HOD at the KM Shah Dental College in Vadodara, and was the vice chancellor at the Sumandeep Vidyapeeth in Sumandeep Vidyapeeth. And presently he holds the post of the principal and faculty dean of Sankalp Chand University, Narsimha Patel Dental College and Hospital, and also he is the faculty dean of the Nutan Dental College under the Nutan Nursing College under the Sankalp Chand University. An acclaimed academician, he has multiple paper presentations to his credit and has conducted various pre-conference courses and hands-on courses in various conferences, as well as he's authored 3 chapters in various textbooks in the subject. He's also a very astute leader and has come up from a very humble background. And as you all remember, the famous Gujarati hospitality, which we enjoyed during the 41st IPS National Conference in Gujarat, it was exemplary and testimony for his leadership skills. And later, a couple of years ago, we also was back in Gujarat for the 21st IPS PG convention, which was conducted in a very impeccable manner. He's also conducted various national and international conferences under his leadership. Friends, he currently holds the prestigious post of the IPS president, as I told you. And for me, he is like a father figure. Though many a times when I stand and take a picture with him, many confuse him for my brother. So that is a secret. And I don't know what the secret or elixir of his youth is. Probably it is to be yoga. I'm sure all of you know that Patel sir is a yoga expert. And he knows many yogic postures. So much so that sometimes when you log into his Facebook account, some of the students might wonder, oh, it looks like Patel sir has posted his picture upside down. But if you look at it carefully, he is in one of his Shirshasana posture. So the picture is same. The picture is perfect. It's only that the sir is in an upside down position. So that probably is the secret of Patel sir's youth and the charm, which you see here on screen now. Friends, his daughter, Dr. Avni Patel, has taken his footsteps and is a successful prosthodontist by herself, and is practicing with him and in the same institute. She's a lecturer in the same institute. And his son, Dr. Rushit Patel, is an oral and maxillofacial surgeon. Dr. Patel sir is married for many years and still in love with his lovely wife, Madam Lily. And probably it all explains the love and youth around him, the charm around him. The love is there for all of us to see. With these few words, ladies and gentlemen, I have great pleasure in introducing our President IPS, Dr. J.R. Patel. Over to you.
Thank you, Dr. Rupesh, for lovely introduction and reminding me that landmark of 1983 when I was doing MDS. Thank you so much for all this introduction, and I am really happy that IPS Karnataka State Branch as well as JSS Academy of Higher Education and Research, Mysore, is organizing this webinar series. You rightly said, Rupesh, that there is no end of learning. It's a lifelong learning process. And the Mysore people, or the rather Karnataka state branch, all people who are very actively involved. And I must say that there are many leaders in IPS from Karnataka state. Even once there was a stage where president was from Karnataka, from Bangalore, president elect from Karnataka, immediate past president from Karnataka. So all leaders are there, and under their leadership, like at present, Dr. Sanath Shetty, Dr. Sunil Dade, Dr. Anil, and all these people are doing great. And you rightly said that, like other branches, they also don't want to remain behind. And for the benefit of all delegates, they have organized this webinar series. They are going to start from today with Stomatognathic stabilization with Occlusal appliance therapy, and many more other topics also they have selected. And you rightly said about the yoga and all these things. They have also included ergonomics. So I am really happy to know that one very important topic also they have included. So I feel proud and happy moments at present to inaugurate this webinar series organized by JSS Academy as well as Karnataka State Branch, IPS Karnataka Branch. So I keep it open for all. Thank you.
Dr. Sunil, can you take over, please? Dr. Sunil.
Yes, sir. Thank you very much. A very good morning to all the galaxy of interactions with us today, and a very warm welcome to everybody. Before we start today's introduction of our President, IPS Karnataka State Branch, I have a very strange request from him, and he has asked me to finish his introduction in just 2 lines. And it's just impossible after going through his CV to do this. So, Dr. Sanath Kumar Shetty is an eminent person with 23 years of experience, and he is presently working as a professor and head in Department of Prosthodontics, Yanapaya Dental College, Mangalore. Dr. Sanath has completed his PhD in the year 2017, and he has been contributed to highly reputed journals as an editor-in-chief, and editorial board of many other journals. He has been the past president and past scientific chairman of ISPRP, and he has been the executive council member of the Indian Prosthodontic Society for 2 terms. Ladies and gentlemen, with this short introduction, we present to you Dr. Sanath Kumar Shetty, the president of the IPS Karnataka State.
Proceed.
Go to the next.
I introduce the panelist for today's program, the webinar series, which is going to commence from today. And one of our panelists is Dr. Sanath Kumar Shetty, as I introduced him now. Along with him, we have our second panelist, that is Dr.
Sanath is online. Dr. Sanath is online. Maybe he can address.
Looks like there's some network issue.
So I'll be introducing our second panelist for today, Dr. Sujendra Mahaurkar, and presently working as a professor and IQAC coordinator in HK's Nijalingappa Dental College and Hospital, Gulbarga, Karnataka. He has been the past president of the IPS Karnataka State Branch, that is 2017-18, and an active member of the Indian Dental Association. Sir is a passionate researcher, speaker, academician, innovative, and his urge to innovate and invent has helped the mankind in this pandemic COVID situation. He has designed a foot-operated soap dispenser, and he is also involved in many innovation research projects that are associated with the Rajiv Gandhi University of Health Sciences, Bangalore, and Karnataka Dental Council. Dr. Sujendra Mahaurkar is an academician with the experience of over 23 years. Thank you for joining us today, sir.
Dr.
Can I take over for 2 minutes with the permission of the host, Dr. Anil Kumar, sir?
Please, please, please.
Yeah, very good morning to all. My special namaste to the President IPS, Dr. J.R. Patel, Secretary Rupesh, and the host, Dr. Anil Kumar Gujari, and my co-panelists and the Secretary of Karnataka State Prosthodontic Society, Sunil Dade, Sanath Shetty, and all the other dignitaries. To take over from the message of the Secretary Rupesh, if a person is determined to learn, he will find out the ways to learn. I think that is what is the bright spot of this pandemic. And it also reminds me of the story of Ekalavya. Though he was not the official student of Dronacharya, he found out ways to take knowledge from what was being taught to the Pandavas, and he could excel in the art of archery, and probably he stood out the best among his Dronacharya's student. I think that story is a apt reminder to all of us that in case we are determined to learn something, we will find out a way to learn and overcome to the situation. I think the necessity is the mother of invention. I think that goes very well during this period, and it is really heartening to see the Department of Prosthodontics from JSS Dental College under the leadership of Anil Pujari and the other faculty taking a lead in associating with the Karnataka State Prosthodontic Society and the aegis of Indian Prosthodontic Society to keep the learning going on, whatever may be the platform, whether it is the physical or online. I think we will keep finding ways to learn and re-equip ourselves. Probably we should all take this opportunity to learn new set skills that will keep us going very long. Probably we all will prevail over this situation which we are not very familiar, and we will definitely come out healthy, safe after this pandemic, and slowly and surely we all will learn new things, as we have all learned about the e-seminars which we have never heard about till now. Now Rupesh is promoting IPS conference of the Nagpur in a very, very huge way online, which is all new anecdotals that you don't have to travel. You can be in your beach shorts to be in the auditorium to listen to the eminent speaker. There are so many ways to see at the positivities. Without taking much time of all the panelists here and the speaker, we all are eager to listen to the presentation by Mahidar, whom I understand is an alumni of JSS, and it's always a great opportunity always to be recognized by the alma mater where you have studied. And I think I welcome all the panelists, and at the same time welcome the speaker to put forward his views. Thank you, sir. Thank you.
Thank you very much, sir. Dr. Dakshani, can you please take over?
Good morning, everybody. At the outset, I would like to, it is a privilege to introduce Mahidar to this webinar series, which is organized by JSS Academy of Higher Education and Research, JSS College of JSS Dental College and Hospital, Mysuru, especially the Department of Prosthodontics, along with the IPS Society Karnataka branch. The President of IPS, Dr. J.R. Patel, sir, Dr. Rupesh, Secretary, President Karnataka branch IPS, Dr. Sanat Shetty, the panelists for today, Dr. Sunil Daded and Dr. Sudhindra. It is, as Dr. Sudhindra very rightly said, Mahidar is the alumnus of JSS Academy of Higher Education and Research and JSS Dental College, Mysuru. He completed his UG and PG from the same institution in 2003 and 2008 respectively. During his post-graduation days, he was guided by Dr. Anil Kumar and all the other faculty at the department. And subsequent to that, he has gone ahead and been a professor. And along with that, he has been an active practitioner. Not only his practice is very well done, he has equipped himself with continuous learning by acquiring quite a few certificates, and he has been recognized as a implantologist, and he has been conducting a lot of guest lectures from in many of the programs, including in Mumbai, Pune, Goa, and also in places like Ghaziabad. And he has been giving lectures on various topics, including the full mouth rehabilitation, FPD, CD, all branches of prosthodontics he has been very well versed with. Along with that, he has got quite a few achievements to his credit. He has been the winner of the prestigious Indian Health Professional Award 2018 as the best prosthodontist of the year. Along with that, he's also been the winner of International Dental Excellence Award 2018 or Dental Speaker of the Year 2018. Not only that, in this thing, he has been awarded as the Outstanding Dentist of the Year 2018. And from the Indian Health Professional Awards 2017, he has got the Dental Talent of 2017 Superstar. All these go to show that he has been an excellent presenter, and he has been able to present in a very effective manner, winning all these awards. So over to you, Dr. Mahidhar, who's the keynote speaker for today, who's going to be talking about stomatognathic stabilization with occlusal appliance therapy. And it's very heartening to know that the number of participants have crossed 300. So it should be a really learning experience today morning. Thank you, one and all.
Thank you, Dakshini. Dr. Mahidhar, just before you start, I think Dr. Sunil wants to talk. Dr. Sunil? Dr. Sunil?
Dr.
Yeah. Sir, Dr. Sanath has joined. Sanath, sir.
Yeah, hi, Sunil. Sorry for all the inconvenience. I was just actually welcoming the head office IPS, Dr. Rupesh and Dr. J.R. Patel, the secretary and the president to this program, and welcoming our today's moderator, Dr. Anil Gujari, and of course our speaker for the day, Dr. Mahidhar. Thank you for consenting to come and present for our entire Karnataka Prosthodontic Society members, the students associated with our institutions, and across the country actually. This webinar series is the first of the many, I assume, that is going to happen from Karnataka Prosthodontic Society. We just thought about getting this done, the webinar series, because this is the time when the continuing dental education programs used to happen in most of the institutions. Now, because of the strange situation of the pandemic that we are in, I don't think physical presence of any speaker or the students in a gathering is possible for us to conduct any continuing dental education programs at our respective institutions. So these webinars are going to be the norm for quite some time coming, I suppose. And there would be a small group of people who would be telling that there's too many webinars and all that. But whatever the knowledge that we can gain from these webinars is so fruitful for each and every one of us. And of course, the postgraduates who are just getting into the field of prosthodontics. I once again thank the JSS Academy and the JSS Dental College for conducting this program for us, and also the speaker of the day. Thank you very much, and thank you for all the sorry for all the technical hitches. Thank you.
Dr. Sunil, could you please take over? Dr. Sunil.
So now I request Dr. J.R. Patel, sir, the President IPS, to kindly release the webinar series.
Sir, Patel, sir, your mic is muted, sir. And I think, Dr. Sunil, you can also post the slide.
I declare it open for all participants. This webinar series with lot of knowledge sharing to all members.
Thank you, sir. Thank you, sir. It was nice. This is the future programs that we were planning to do. Thank you very much for your support. Now, Dr. Mahidhar, I think you can start.
Thank you, sir. Thank you everyone who is present here. Thank you Anil sir, thank you Dakshani ma'am. Thank you President IPS. Thank you to all the dignitaries. Thank you Dr. Rupesh sir. I have known you through Facebook. So first time I think we are communicating with each other. And it's a great opportunity for me as an alumni of JSS Dental College to speak on one of my favorite subjects, the stomatognathic system equilibration with occlusal appliance therapy. So I'll not take much time speaking about other things. Let me go into the presentation straightforward. So when we see this as the first picture of a presentation, we understand that the evolutionary process has gone from top to bottom. The evolutionary process has not come from the below level to the top level. So what Sir Dawson always tells us is whenever you are planning something in the stomatognathic system as a unit, you always have to consider the first structure as the TMJ. Then you have to go on to the muscle, which is formed in the next process, and then you have to come to the teeth, which are formed in the sockets. So whenever we speak about any kind of equilibration procedure, let it be a small kind of splint therapy, a kind of selective grinding, a kind of orthodontic procedure, or a prosthodontic procedure, we always have to consider the TMJ as the first entity. We need to make sure that the temporomandibular joint is in its comfortable and healthy and healthiest position. And then we have to go on to the muscle, see that the muscle is also in its comfortable space. And then we need to take care of the teeth, which are present in the sockets. The moment we start going backwards, first we take teeth into consideration, we put crowns, or we do selective grinding, or we do orthodontic or prosthodontic procedures over the teeth without making the muscle and the TMJ happy in its own space, then the treatment procedure would be wrong. So always make sure that the TMJ is considered first. Whenever we talk about any kind of equilibration procedure, then the muscle is taken into consideration. And finally, we go on to teeth to do any kind of procedure to make sure that the stomatognathic system is happy, finally. So starting with this slide as an introduction, I would start my presentation on the stomatognathic equilibration with occlusal appliance therapy. So this is the order we need to consider whenever we are doing any kind of equilibration procedure. So what are the different types of pains we see in our dental clinics or dental operatories? The first pain is your toothache. Whenever we talk about toothache, it is not necessarily that it is pulpal or periodontal in origin. We need to take different kinds of pains into consideration when we consider or localize a certain kind of pain. The source could be different, the site could be different. So that is one thing which we need to remember whenever we see certain kind of patient with certain kind of pain in our dental operatory. So whenever we have toothache, the moment we rule out the periapical and periodontal pathology, whenever it is concerned with the tooth, we need to open up our mind and see if there is any other source of pain that is related to the tooth. We see a lot of headaches in our practices. The moment we see headache in our practice, we usually think it is not our specialty. So we refer it to a general med or any other MBBS doctor, and then we try to rule out the headaches. Fair enough. If there is a headache which is because of any other source, then once it is ruled out and the headache is not coming down for the patient, then we need to consider the intraoral and extraoral factors as well to rule out the headaches. We see a lot of neck aches, we see a lot of back pains, we see a lot of shoulder pains. So all these things are also related to the intraoral and the extraoral mechanism that is going on in the stomatognathic system. So once we rule out all these pains, like neck ache, back pain, sometimes ear pains, the ear pains are also related to the TMJ. The ear pains are also related to the stomatognathic system. So if you send a patient to ENT and the ENT rules out that there is no possible factor I see for the ear pain, then you have to consider yourself to take the responsibility and search for the factor to rule out whether the ear pain is because of the stomatognathic system or not. You see sometimes eye pains. So even the eye pains or supraorbital pains are related to the stomatognathic system. So you have to remember that the source and the site of pain might not be the same always. The source could be different, the site could be different. Suppose I have a source inside the oral cavity, the site of the pain could be outside the oral cavity. So there could be a distance between these two things, because of which the pain could be localized, the pain could be generalized. We need to catch hold of the source to rule out the site of the pain. So this is one important point which we need to remember before we actually understand what is happening within the stomatognathic system when the face in toto is considered as a subject. Suppose I have a pain in the front part of the ear. The source could be somewhere inside the oral cavity, because of which the pain is actually seen here. The pain is localized here. So whenever the patient comes to you with a pain in front of the ear or in the TMJ region, it doesn't mean that the source is the TMJ. It could be a different entity altogether. It could be a small interference inside the oral cavity which is creating a pain outside the oral cavity. Let it be the TMJ, let it be a supraorbital pain, let it be a pain behind the ear, let it be a neck pain, let it be a shoulder pain, let it be a back pain. There are a lot of instances where we just remove a small interference inside the oral cavity and the back pains of the patients are healed or reduced to a certain extent. So we need to generalize, we need to see where the source of pain is there, and then we have to catch hold the site of the pain and then treat accordingly. So that is what we need to understand when it comes to the stomatognathic equilibration. It's a whole unit. It's not just the tooth. It's the tooth, it's the muscle, it's the joint. And we need to actually balance the whole system together and then find out where the problem is. Coming to the next slide, what are the types of TMDs we see in the general practice, in the dental office? Broadly classified into extracapsular and intracapsular problems. So if you talk about the extracapsular problems, it is usually outside the capsule which holds all the parts of the temporomandibular joint. So if you see a temporomandibular joint, you have a fibrous capsule that encapsulates all the segments. So whatever is present outside the capsule, it's usually the muscle, it's usually the tooth. So it's a combination of occlusal muscle disorders, which we see in the dental practice, which is termed as your extracapsular disorders. But when it comes to intracapsular disorders, whatever is present in this fibrous capsule, those are responsible for the intracapsular disorders. And they are the true TMJ problems. Today, we are not dealing with the true TMJ problems. We are dealing with the occlusal muscle disorders and then how to equilibrate such problems to make sure that the stomatognathic system is in balance finally. So when it comes to the true TMJ disorders, there is a separate protocol. When it comes to the extracapsular disorders in the form of muscle disorder, there is a separate protocol we need to follow. And what is the protocol? We'll see in the further slides. So if you see this picture, you'll understand that there is a lot of space in between the upper and the lower teeth, because there could be one interference somewhere on any of the teeth inside the oral cavity, which is lifting the other teeth from each other. That interference is responsible for a muscle disorder. That interference is responsible to make sure that there is no balance in the stomatognathic system. So what is the most common causative factor for occlusal muscle disorder is a tooth interference. So if we find out that interference, if we catch that interference, and then we make sure that the interference is not there in the oral cavity, then we are making sure that the whole stomatognathic system is under equilibrium. And that procedure is known as equilibration of stomatognathic system, in simple words. So what is a tooth interference? A tooth interference is nothing but if one tooth lifts all other teeth out of occlusion in ICP, then it's called an interference. We need to understand two terminologies here. One is what is ICP and what is centric relation. Whenever I close my mouth in a certain fashion and there is a maximum intercuspation between the upper and the lower teeth, in simple words, it is known as intercuspal position or maximum intercuspation. It is not joint related. So what we need to understand, it is teeth dictated position. So when I open up and close it in static occlusion, the position which we are getting in between the teeth is known as intercuspal position or the maximum intercuspation. But if I guide the mandible with certain norms so that it becomes a joint related position, then it becomes a centric relation. So not necessarily everyone offers inside the oral cavity, the centric relation in the joint is equal to the maximum intercuspation inside the oral cavity. It could be different. My maximum intercuspation would not be equal to centric relation, could be equal to centric relation. I don't know what it is. In order to know, in order to find if my maximum intercuspation is equal to centric relation, we need to do something called diagnostic mounting. We need to take the casts of the maxillary arch and the mandibular arch. We need to mount them with the help of few things. And then we need to find out if the centric relation is equal to maximum intercuspation inside the mouth. And the whole process of doing this is known as diagnostic mounting. We'll see how that is done and how to catch hold of a particular interference inside the oral cavity and how to eliminate that interference. So what happens if there is an interference? If there is an interference, then it sends signals to the brain. And what brain does, it sends signals to the muscle. And what muscle does, muscle tries to shift the jaw away from that interference or tries to grind that interference. Suppose I have an interference somewhere in the oral cavity, I close my mouth. Then it hits the interference first and then goes into maximum intercuspation. That is what usually happens inside the oral cavity. So the moment it hits the interference first, the brain gets alerted. And brain sends signals to a muscle which is known as lateral pterygoid, which is attached to the condyle. And the lateral pterygoid gets signals from the brain and it gets activated and pulls the condyle away from its comfortable position. Why it pulls the condyle? Because it wants to escape the interference. It tries to get the jaw into a comfortable position, which is not there because of interference. In that process of getting the jaw into a comfortable position, patients develop parafunctions. So when it tries to erase the interference inside the oral cavity with these movements, patients develop something known as bruxism. So bruxism is not only a psychosomatic disorder, it is also interference related when it comes to the oral cavity. So if you have an interference, the muscle which gets signals from the brain gets activated, it tries to pull the condyle forwards and then the jaw tries to escape the position. In this procedure or the fight that is happening between the jaw and the muscle, you develop what is known as bruxism or parafunction. So this is what happens inside the oral cavity. And that's why patients come to us with a lot of complaints. They come to us either by telling us night times, I'm hearing a lot of sounds. My family members are hearing a lot of sounds. Daytime, intentionally or unintentionally, I am doing certain kind of movements with my mouth. They also come and tell us that I have some kind of pain here. I have post-auricular pain, I have neck pain, I have shoulder pain. But without finding this interference, if we just send the patient to an orthoped, what an orthoped can do, he will or she will rule out all the possible causative factors and tell us there is no problem, as I find inside. And once you hear that there is no problem, then you need to become an oral diagnostician. That's why dentists are called oral diagnosticians. We need to find out the causative factor which is responsible for such kind of pains. Not only the tooth pain, it could be any kind of pain starting from the ear to the eye to the back. So the pains are generalized in various categories. So that is why this point is very, very important for us to understand what is an interference and what is the difference between maximum intercuspation and centric relation. Now, as I said, that interference is something which is coming in between the maximum intercuspation and centric relation. What happens if I eliminate this interference? The moment I start eliminating this small interference inside the oral cavity, the maximum intercuspation inside the oral cavity will become equal to the centric relation. The moment centric relation is equal to the maximum intercuspation inside the oral cavity, the whole stomatognathic system is in equilibrium. All the muscles will become relaxed. There is no interference inside the oral cavity. It becomes interference-free occlusion. And the moment muscles start becoming relaxed, all kinds of pains, all kinds of parafunctions start slowly coming to control. It takes some time, but yes, it will be under control. So that is why the interference is one important entity or important terminology to be understood, to be diagnosed, and to be eliminated. The elimination procedures can be of different types, which we'll discuss. But catching hold of the interference is of two ways. You can do it intraorally or you can do it extraorally. We'll see how we do it. There is a test which is known as load test that we all need to remember, because before we start with any kind of equilibration procedure in the stomatognathic system, we need to rule out that the TMJ is healthy. If the temporomandibular joint is not healthy, if there is an intracapsular disorder or a true TMJ disorder that is present here, and if you don't find out that disorder and start with full mouth rehabs, start with splint therapies, start with selective grindings or orthodontics, the problem will be doubling. You are actually making sure that the problem is increasing for the patient. So if you find that there is any kind of true TMJ problem, we have to terminate the occlusal equilibration procedures then and there itself. We need to treat this first. We need to make sure that this is happy, and then we have to come to this and this. So there is one test which is known as load test, which is done in order to find if the TMJ is healthy in its space or not. So if you see this picture, you will understand that Mr. Rocabado has given a map of pain. So in this map of pain, the load test is done in this manner. We take the thumb, we keep the thumb over the occlusal surface of the molars inside the oral cavity. We hold the mandible with the other fingers. We try to push the mandible backwards, and then with the other hand, we come onto the angle and we try to lift the angle. What am I doing with this kind of motion? If you see the mandible as one entity here, if I push the mandible back and lift the angle of the mandible, I'm actually taking the joint into an anterosuperior position. I'm taking the condyle into the anterosuperior position when it comes to the glenoid fossa. If I don't lift it at the angle and I just push it back, I'm distalizing the mandible. I'm pushing the condyle backwards onto the retrodiscal tissue. So it is always important to hold the mandible, push it back, and then lift it at the angle of the mandible so that I am taking the jaw into anterosuperior position when it comes to the glenoid fossa. And when I apply this pressure and patient complains of pain, doc, I'm feeling something sensitive in my joint, with mild pressure, with moderate pressure, with heavy pressure, then you should understand that there is some kind of intracapsular pathology that is existing inside the joint. Usually, if there is any true TMJ disorder inside the joint, with mild pressure, patients will complain of pain or sensitivity. So the moment you understand patient is not comfortable when I'm doing the load test, immediately you should send the patient for an MRI examination. You should get the joint scanned. You should see what is happening inside the joint. You should target the joint, and then you have to treat the joint accordingly. Once you treat the joint, then only you have the scope to treat the muscle and the teeth simultaneously after that. If you forget this and start treating these two things, you will not have any kind of improvement in the joint. It starts going bad. It starts going worse day by day. So always make sure that a load test is performed before we start with any kind of stomatognathic equilibration procedure. So this is one important point we all need to understand. There is one more test which is known as stabilization test or immobilization test. What is stabilization test or immobilization test is, we tell the patient to clench, and then in that clenched position we tell the patient to do minor play of the jaw. If I am doing this minor play of the jaw in this clenched position, the joints are immobilized. The joints become mobilized only when I open my mouth, close, or do the protrusive and the laterotrusive movements. If I clench, it is becoming static. So in clenched position, you tell the patient not to open up and do the movements with the mandible in that minor play that happens in the intercuspal position. So when the patient is doing this minor play of movements in this clenched position, if patient tells you that I have pain somewhere here, then it means that it is the muscular pain that is causing. It's the muscle that is causing the pain. It's not the joint, because the joint is immobilized now. The joint is not moving inside. So when the joint is not moving, there is no possibility of the joint giving you pain. So do these two tests simultaneously. One is load test and one is immobilization test or the stabilization test. And rule out whether the pain is because of the true TMJ disorder or the pain is because of occlusal muscle disorder. Once the load test is negative, yes, I can safely proceed with my steps in equilibration procedures. If the load test becomes positive, then you have to tell the patient to get the joint scanned, you have to refer it, and then you have to see what is happening inside the joint and treat accordingly. That's a whole different procedure, that's a whole different flow of subject. But if the immobilization test is positive and load test is negative, we proceed with stomatognathic equilibration procedures. So this is what I was telling. If load test is positive, it might be a true TMJ, problem. So get it scanned, rule out the problem. If stabilization test or immobilization test is positive, it could be related to a muscular problem. So what we do is we start with the next procedures. We deprogram and we go for equilibration. And what are the types of equilibration when it comes to the stomatognathic system? The first type of equilibration when it comes to the stomatognathic system is your occlusal appliance therapy, which is also known as a stabilization splint. You have different kinds of occlusal appliances, but when it comes to the occlusal muscle problem, equilibration of the system together, we have one splint, which is known as stabilization splint. So we check with the splint if the problem is coming down, and then we proceed with probably an irreversible mode of treatment. So this is always reversible. I can take out the splint anytime, it becomes reversible mode of treatment. But if I do something which is irreversible, it starts with selective grinding. I'm taking away some enamel over the teeth. It starts with prosthodontics. I'm restoring a part of tooth. It starts with orthodontics. I'm repositioning the teeth inside so that everything becomes equilibrated. And finally, it becomes a surgical procedure. If all these things do not work out, then we have to go for surgical procedure. And that's the last thing. Probably if you have a prognathic maxilla, retrognathic maxilla, or prognathic mandible, retrognathic mandible, which cannot be corrected either with selective grinding, prostho or ortho, then we think of orthognathic surgeries in order to equilibrate the stomatognathic system. So the first point which we start with is your stabilization splits. So these are the two objectives of any kind of equilibrations. Let it be selective grinding, let it be ortho, prostho, whatever we are doing inside the oral cavity. The main objective of the equilibration is mutually protected occlusion in centric relation. We are not taking the maximum intercuspation into consideration here anymore because we have an interference in maximum intercuspation. So we need to change that maximum intercuspation into centric relation by taking out that interference. So from here, we're talking about the centric relation and not the maximum intercuspation. In centric relation, we have to create an occlusal scheme inside the oral cavity so that it is mutually protected. In most of the cases. In some cases, it could be a group function also. That's a variation. But in most of the cases, we tend to target the mutually protected occlusion if your canine is strong, periodontally strong and present. The second point, what we need to understand is your interference-free occlusion in centric relation. There should not be any interference. The interference has to be taken out. How can we take out the interference? I can either eliminate the contact between the posterior teeth. I can make sure that the posterior teeth are away from each other, or I can remove that interference. I can restore the tooth with interference, or I can reposition the tooth so that the interference is lost. So these are different kinds of modalities which are present in order to make sure that a small interference inside the oral cavity is eliminated so that we tend to equilibrate the stomatognathic system as one unit in toto. So if you see a mutually protected occlusion, you will understand a few things. Whenever there is some kind of stomatognathic equilibration, the posterior teeth, when you do a static occlusion, when I open up and close, the posterior teeth should take a lot of load and the anterior teeth should take less of load. That is the first point in simple words we need to understand about static mutually protected occlusion. So here the posteriors are helping the anteriors. Why is it called mutually protected? Is one segment is helping the other mutually. The posteriors are helping the anteriors by taking up more load. We have a concept in complete dentures that you should have an overjet and overbite. You should have an open bite. But when it comes to the natural teeth, when it comes to fixed processes, in case of full mouth rehabs, you should never maintain an open bite between the upper anteriors and the lower anteriors. This is a very important point to understand. We need to have a contact in between the maxillary and the mandibular incisor teeth. And from that contact, you have something known as anterior guidance. If you don't provide this contact, as long as there is an open bite, when the mandible starts moving forwards, you still have the contact of posteriors happening, which I don't want. So the main intention of mutually protected occlusion is when the mandible goes front, there should be immediate and posterior disclusion progressively. So if I don't have this disclusion posteriorly, what happens? As long as I travel with my mandible forwards or sidewards, there is continuous friction that is happening between the posterior teeth. And that friction might lead to muscle problem. That friction might lead to excessive wear of the posterior teeth. That friction might lead to TNJ problem. So all these are interrelated. So we tend to aim, the objective is to make sure that in static occlusion, posteriors should take more load than anteriors, though they have a contact. In dynamic occlusion, when I move forwards in the protrusion, there should be immediate and progressive posterior disclusion of the teeth, so that the anteriors are taking up the load in protrusion and the posteriors are getting away from the load in protrusion, just to make sure the other parts of the posterior segment are safeguarded. They're safe. As long as there is continuous oblique forces that are falling on the posteriors in the dynamic movements of the mandible, the other parts are not safe. So to safeguard them, we incorporate what is known as mutually protected occlusion. So we have talked about the static, we have talked about the protrusion. What happens when it comes to the late protrusion? When it comes to late protrusion, as long as I have canine which is very strong periodontally, as long as I have canine which can support the mandible during lateral movements, we prefer as a standard to give canine guided occlusion. Whether it comes to the prosthesis or whether it comes to the natural teeth equilibration. If canine is weak periodontally, if canine is absent, or if canine has a prosthesis, then we tend to share the load in the lateral movements. So as long as your canine is not there, as long as your canine is periodontally weak, as long as your canine is having an implant, say so, then we need to spread the contacts laterally and convert it into either a partial group function or a full group function. When I speak about the partial group function, we probably take one premolar as a support along with the canine in the late protrusive movements. When it comes to the full group function, we take the canine, premolar, mesiobuccal cusp of the first molar. So till then, we spread the contacts when it comes to the group function. Okay, when I'm going towards this side probably, then my canine is guiding the system. What happens to the contacts on this side? On the non-working side, you should not have any contacts. On the working side, you should have canine. All the other teeth should be discluded. On the non-working side, even the canine should not have any contact. So it's only the canine on the working side that is guiding the occlusion in the laterotursal movements. Whereas it comes to the other side, it is just non-interference of the teeth that is happening on the balancing side. So if you incorporate this kind of occlusal scheme, either with selective grinding, either with prosthodontics, either with orthodontics, then you are getting what is known as stomatognathic equilibration inside the system. And once equilibration is obtained with this kind of occlusal scheme inside the oral cavity, then all the kinds of problems which are related to this start disappearing one by one. So that's the main objective of what we are talking today in the form of stabilization splint. Okay, so if you see this picture, this is your static occlusion. In static occlusion, as I said, the anterior teeth also should touch each other. Though the intensity of the contacts, though the force that is falling on the anteriors is lesser than the force that is falling on the posteriors, but yes, we need to have a contact in the anterior region. When it comes to the dynamic end-to-end occlusion, starting from the static to the dynamic, we should see a posterior disclusion happening. And also make sure that one tooth is not taking up the anterior guidance here. You should have at least 2 teeth guiding the jaw. You should have at least 3 teeth guiding the jaw or 4 teeth guiding the jaw. One tooth guiding the jaw is again harmful to the system. Either this tooth will go for a toss in the future or this tooth will give up. So it's always beneficial to have anterior group function rather than single tooth that is guiding the jaw. So this is a problematic case when it comes to different kinds of movements. If you see the side movements also, you'll understand there's a lot of group function here on the working side. Though here there is some kind of disclusion, there is a group function. So such kinds of group functions on the working side would be harmful to the system. Not necessarily you need to correct every kind of group function. There is also a statement in equilibration saying that don't disturb a sleeping snake. If you don't see any kind of sign, if you don't hear any kind of symptom from the patient, it is something called adaptation that happens inside the oral cavity and inside the joint. So as long as you don't have signs and symptoms, do not disturb it. But if you see signs, as signs always precede the symptoms, you need to alert the patient. See, this is what is happening inside the oral cavity. This is what is there inside the oral cavity. I see some signs. So let's proceed with the treatment as soon as possible. Patients get alerted. Patients will have a knowledge about it. And then it's up to patient to decide whether the patient has to come for the treatment or not. What is our duty as oral diagnosticians is to tell the patient that the signs always precede the symptoms. So I'm seeing something now. You might get your symptoms later. You might come to me with pain. So be alert and come to the treatment as early as possible. So that's how we need to proceed when it comes to the examination part, at least. When we see when in protrusion you have posterior disclusion or not, if there is any good anterior group function, in the lateral movements, if you have canine guided occlusion, if you have group function, all these things have to be examined first when it comes to the occlusal examination. You have to note it down and alert the patient that this is happening. No signs and symptoms, then it's better you don't touch the sleeping snake. So this is a perfected formula for occlusion when it comes to Sir Dawson. So what Sir Dawson says is you should have posterior dots and anterior lines, in simple words. Why posterior dots? Because you're going into static. Anterior lines because you're going into dynamic. Why not posterior lines? Because I don't want my posterior teeth to rub against each other, to touch against each other. That's why we have anterior lines and posterior dots when it comes to the occlusal scheme as such. Okay, so dots in the back and lines in the front is what we actually aim for when it comes to the equilibration procedures. Okay, patient has come to me, patient sat on the dental chair, patient told me that I have this kind of pain here. I went to ENT, I went to orthoped, I went to general med, it is not coming down. Everything is ruled out. Then what is the first step I do? I do a load test. I do all these occlusal examinations, I take pictures, I do what is known as load test and immobilization test. If the load test is positive, then I immediately tell the patient to get an MRI scan. I will see what is there in the joint. I target the problem and I treat it. In case the load test is negative and immobilization test is positive, I take a normal OPG. I would not go for probably a scan of the joint and then proceed with the next step of equilibration in order to see what is happening inside the oral cavity. Just to see. I cannot just open up the mouth and see what is happening inside the oral cavity. So we need to see what is happening inside the oral cavity by a procedure what is known as diagnostic mounting. So in order to have this diagnostic mounting, the first step what we do is known as deprogramming. Can I request to put the questions later on once I finish the session, because the board is coming down every time I am speaking here. So I request everyone to put the questions once I finish the session. Thank you. So the first step after the load test is negative is known as deprogramming. So when I say what is deprogramming, the deprogramming is about muscle. It's not about teeth. It's not about the joint. It's not about anything else. It's about a muscle. A simple muscle needs to be deprogrammed in order to get a correct centric relation. This is a simple explanation of what is known as deprogramming. So if you see this picture, we'll understand that there is a muscle which is known as lateral pterygoid. You have two heads of lateral pterygoid, the upper head or the superior head, the lower head or the inferior head. So what we do when it comes to the lateral pterygoid is, if there is an interference, as I said in the previous slides, there would be a hyperexcitability of the lateral pterygoid. The lateral pterygoid becomes excited when there is interference inside the oral cavity. And whenever the lateral pterygoid gets excited, it tries to pull the condyle forwards. That's the action of lateral pterygoid. It tries to pull the condyle forwards from its position, from its original position. So the moment it tries to pull the condyle forwards, what happens to the centric relation? The centric relation is not the same anymore inside the joint. It is not the same anterosuperior position that we want finally. So we want to make sure that the lateral pterygoid is not excited anymore. We want to calm it down. We want to relax the muscle. The procedure which we do to relax the lateral pterygoid muscle is known as deprogramming. So what in simple words we are doing is we are eliminating the contact between the posterior teeth. As simple as that. As long as my teeth are in occlusion, as long as my teeth are in contact with each other, there is a brain signal that is being sent from here to here. The moment I open up the posterior section of the teeth, that signal is cut off. There is no more signal that is sent to the brain and from the brain to the lateral pterygoid in turn. So the moment the signal is cut off between the teeth and the brain to the lateral pterygoid becomes relaxed. It is no more being guided by the brain. Brain is not telling the lateral pterygoid, come on, you have to do some job there. You have to make sure that the jaw is away from the interference. No, it's not getting any other signal now. So it becomes relaxed. The moment it becomes relaxed, it goes back to its original position. we can guide the jaw easily without any tension from the lateral pterygoid. And then we probably get the true centric inside the joint. So that is the whole mechanism of doing a procedure which is known as deprogramming. So this is a simple diagram which can basically get to the point. I introduce an anterior platform in between the upper and the lower anterior teeth so that I have a posterior disclusion. The moment I have posterior disclusion, by introducing an anterior platform in between the upper and lower teeth, the lateral pterygoid is relaxed. And if the lateral pterygoid is relaxed, I can easily guide the joint to centric relation. Or the joint can go back to centric relation without any hold by the muscle in the anterior direction. So that is, in simple words, what is known as deprogramming. So there are different devices that are available in the market as stock deprogrammers. There are different devices that are available in the market by which you can reline the device and use as an anterior platform. This is your simple Lucia jig, which is used. You need to put some material here, reline it, and then place it in the anterior segment so that the lower teeth are falling on the platform straight. The platform should never be oblique. It should never be angulated. Because the moment the platform is not straight on a deprogrammer, and if it is probably in this direction or in this direction, you will have wedging of the condyle back. As long as the lower anteriors fall on a straight platform, the condyle is safe. If the platform is not straight and if it is angulated or oblique, then the moment the lower anteriors fall on the platform, the mandible becomes distalized. The condyles are wedged back, and that creates a problem. The condyles go and touch the retrodiscal tissue and the patient jumps with pain. Pain, instead of decreasing, becomes more. So always make sure that this platform is straight and perpendicular to the lower incisal edges of the mandibular anteriors. That is an important point. So when you reline it, you should make sure that this plane is according to the occlusal plane of the maxillary arch. So this is your Lucia jig. This is the labial portion of the Lucia jig that goes over the teeth. This is the platform on which the lower anteriors fall. And this is the intaglio surface of the Lucia jig, or the internal surface where the teeth come and sit on it. So if you see this picture, you will understand that the teeth are going inside, and you can reline the Lucia jig with the material. Let it be your medium body, let it be bite registration paste. Sometimes cold cure acrylic is also used, which I don't prefer. This is your Coase deprogrammer, which is a simple Holly appliance which you fabricate inside the oral cavity, over which you build up an anterior platform. One of my most favorite deprogrammers, because number one, patient will not have a social stigma of wearing a deprogrammer and going outside to talk to people. Because in such deprogrammers, you will have a labial extension which can be seen when the patient smiles or speaks. When it comes to the Coase deprogrammer, you don't have that labial extension. You just have a palatal plate on which you have a platform which is built again in order to deprogram. So the palatal platform is not on the labial side, it is on the palatal side. So the social status of the patient is improved much when it comes to the Coase deprogrammer. Number two, I can use this deprogrammer in deep bite cases also, in class 2s also. Whereas here it becomes a problem when I'm using in class 2s and deep bites. So in this, I can build up the platform in such a way that I can deprogram a patient with class 2 malocclusion. I can deprogram a patient with some deep bite inside. Not only that, I can also use this Coase deprogrammer in CCPs, the constrictive chewing pattern cases. So what is the normal chewing pattern? We eat, we go back, and then we eat, like a cow. But in case of CCPs, constrictive chewing patterns, we eat like rats. We come front and then we go back. We come front and then we go back. So in such cases, usually the condyle is getting distalized because it is coming front and going back. It's a reverse pattern of chewing some patients we observe. So in such cases also, we can use quiz deprogrammer beneficially inside the oral cavities. So that's the main advantage of this quiz deprogrammer that can be used universally in most of the cases. When it comes to a leaf gauge, it is flexible. It is not that rigid. We also get rigid leaf gauges now, but usually when it comes to the universal availability of the leaf gauges, it is usually flexible. So that's the only disadvantage of leaf gauge, where you might actually distalize the mandible back and the condyle can go and hit the retrodiscal tissue. But practically, if you are used to use a leaf gauge, then it is a wonderful tool to deprogram. You can assemble certain amount of leaves to get certain thickness, and then you can chair side deprogram the patient as well. The leaf gauge is also used to get that first point of contact inside the oral cavity, chair side. What happens when I deprogram chair side? I'm actually taking the mandible into centric. So I start removing one leaf after the other till the patient tells me, doc, I'm finding some contact intraorally somewhere. That is your first point of contact, which is known as retruded contact position. So in order to find that first point of contact inside the oral cavity chair side, we can use a deprogrammer which is known as a leaf gauge. So that's the advantage of a leaf gauge. It is also a wonderful appliance that we can customize and use in the oral cavity. What do I mean by customizing is we can pile up leaves and then we can start removing the leaves one by one till we get that first point of contact. So this is your NTI-TSS, the nociceptive trigeminal inhibition tension suppression system. Usually the NTI-TSS system is used for migraine headaches. It is a normal deprogrammer like a Lucia Jake, but the only difference is you have a minor platform here which concentrates a one point when it comes to the deprogramming. And they say that actually helps the temporal headaches to reduce inside the stomatognathic system. And this is your unwind by one of my dear colleagues and friends, Dr. Moyes. So this is an Indian product which was released into the market. It also has its own advantages when it comes to the platform. The platform is customized so that you can use it in class 1s, class 2s, and class 3s also. So you have different types of deprogrammers that are available, but my most favorite is the COES deprogrammer, just for the fact that it can be universally used in many kinds of situations. It is comfortable for the patient also to leave it inside the oral cavity for a certain amount of period of time. Or you can customize according to the patient by doing a pattern resin deprogrammer. A small chunk of pattern resin can be mixed, can be placed over the anterior teeth on a cast, and then you can make a flat platform. You can just take a glass slab and you can rub it over the glass slab so that you get a flat platform, and then you can customize inside the oral cavity. You can make sure that the lower anteriors are falling perpendicular to the platform. You make sure that the posterior disclusion is around 2 millimeters away from each other. Suppose I have 7 which is supraerupted. That supraerupted tooth is taken as an indication in order to get that space in between the 7 and the opposite arch. So that's how we decide whether we get around 2 mm of posterior disclusion or separation when we introduce an anterior platform in the form of deprogrammer. The next question what we might get is how many days this deprogrammer should be used, how long it should be used in a day. Usually if you give a deprogrammer to the patient, we would ask the patient to use the deprogrammer throughout the day except when he or she eats or chews on something. Rest of the time, a deprogrammer should be used. How long? Usually, when it comes to deprogramming, we do the deprogramming for around 1 week to 2 weeks. Though there is a concept of supraeruption of the teeth, overnight, we need to recall the patient and then we need to recheck whether there is some kind of problem that is happening inside the oral cavity. So there are literature supporting 48-hour deprogramming. There are literature supporting chair-side deprogramming. But what we do is we give some time for the lateral pterygoid to relax completely and then target to get the real centric inside the stomatognathic system. So that's what we do when it comes to the deprogramming. And once the deprogramming is done, we take a phasebow record. The phasebow record is done in order to get the orientation of the maxilla in relation to the skull. The orientation of maxilla in relation to the hinge axis. So we capture that orientation, we mount the maxillary cast on a semi-adjustable or fully adjustable articulator in the same orientation that is present inside the oral cavity. What happens if I just take a maxillary cast in my hand and mount it arbitrarily without taking a phasebow record or without taking a dentofacial analysis record? What happens is, if I carry it with my hand and mount it on a semi-adjustable articulator, I am mounting it in a different direction, in the direction my hand is supporting, and not in the orientation which is present inside the cranium. So if I probably shift the direction of the maxillary cast and mount it on a semi-adjustable articulator, my final processes would be in a different direction when I put it inside the oral cavity. And there you get the high points, and there you get interferences. So in order to escape all these minor corrections later on, we capture the orientation of the maxilla and then we transfer it into a semi-adjustable articulator the way it is inside the cranium. And then we mount. And once the maxillary cast is mounted in a semi-adjustable articulator, and once the deprogramming is done, we get the centric record. We do Dawson's bimanual manipulation technique to record the centric, and then we take the centric record and then we mount the mandibular cast. So once the maxillary and mandibular casts are mounted with the help of phasebow and a centric record, then we find that first point of contact in centric relation to see where the problem is actually happening inside the oral cavity in the absence of lips and cheeks. I cannot put my head inside the oral cavity and see where the problem is happening. With articulating papers or occlusal indicators, I might not actually get that first point of contact very clearly because of saliva, because of lips, because of cheek, tongue. So I need to eliminate all these things, put the maxillary and the mandibular cast mounted on a semi-adjustable articulator, and then find out that first point of contact with convenience. That is the main objective of doing all these things before diagnostic mounting. So if you do all these things, then you get something known as a diagnostic mounting in this form. So this is one of the phasebows which I use. This is centric interocclusal record by alu wax cake, and then we mount with different records. After I mount in the centric relation, maxillary and the mandibular cast, I take a protrusive record and I set the horizontal condylar guidance as well. This is also important for me because I need a posterior disclusion when it comes to the back teeth or the posterior teeth. So this guides me for that posterior disclusion, the HCG, the horizontal condylar guidance. For that, the protrusive records help me. I need not go ahead with alu wax records when it comes to protrusive because we are doing it at the same time. We're not sending it to the lab. I myself take the protrusive records, put it on an articulator, and then customize or program the articulator in such a way that I get the reading for the HCG. So once the HCG is set, once the lateral is set, Bennett angle we usually set at 15 degrees. And once these two things are set on an articulator, then what we do, we remove the centric record. Once we remove the centric record, we have a space now uniformly in between the maxillary and the mandibular cast for the thickness of centric record we have removed. The moment we start unscrewing this or opening this screw on the incisal pin, the maxillary cast drops down onto the mandibular cast. It falls straight down. So when it falls straight down in centric relation, the first point we are getting in between the maxillary and the mandibular cast is known as retruded contact position. So we take an articulating silk that is usually preferred when it comes to the casts. So it is one of the occlusal indicators which is known as articulating silk. It is around 80 microns to 100 microns. So you can spread the silk in between the maxillary and the mandibular casts, open up the screw, the incisal screw, the maxillary member falls straight down onto the mandibular member. Now, And once it falls straight down, you can notice one kind of initial point of contact somewhere in between the maxillary and mandibular teeth. From that point, we plan. Suppose there is a first point of contact in between the first molar of the maxillary and the mandibular teeth. Then from that point, I plan whether I have to do selective grinding, whether I have to do prosthodontics, whether I have to do orthodontics. There is a rule which is known as rule of thirds, by which we decide whether we have to go with this or this or this. So whatever we have done till here is just to diagnose a simple first point of contact. And whatever we are going to do from now is the real treatment planning. So in order to get the treatment planning, we need to do something known as diagnostic mounting. So once the diagnostic mounting is done, then we decide whether we have to go to this or this or this. Suppose I have taken selective grinding as my treatment planning according to the rule of thirds. Then what I do, instead of going straight away with selective grinding, which is an irreversible procedure, the moment I take off the enamel, it is gone. It is not coming back to me. I give a splint, which is known as stabilization splint, inside the oral cavity for a certain period of time, probably 1 month or 1.5 months. And once I give the splint inside the oral cavity, I see whether the symptoms are coming down, whether the pain is getting reduced, whether the patient is feeling comfortable now, happy in his own or her own space. And once patient tells me that, I have a positive feedback, I'm happy now with the splint in centric relation with mutually protected occlusion that is incorporated in the splint, then I target the irreversible mode of treatment, which is permanent. And that is either your selective grinding or prosthodontics or orthodontics. So a splint therapy is actually telling you or hinting you if you can proceed with the irreversible mode of treatment. A reversible mode of treatment is taken as a first option. Look into the details, how the patient is recovering, and then we can proceed with irreversible or the permanent mode of treatment in the form of these three things. What Sir Dawson tells is it is triple R, the RRR. Either it is reshaping, restoring, or repositioning the teeth. You have to select either of these three things, but before you select either of these three things, you make a splint in centric relation. The splint should have mutually protected occlusion. Give it to the patient in certain vertical dimension. And then if patient comes back to you and says he or she is happy, go ahead with one of the permanent treatment modalities. It becomes easy for you to actually assess what is happening with the patient. That's the main intention of splint. Now, you guys can have a question that when I'm using a deprogrammer, can I not use it as a splint? No. Deprogrammer is only an anterior partial coverage appliance. Whereas when it comes to a splint, it is also a full coverage appliance. It also has a posterior coverage. And on a deprogrammer, I don't have mutually protected occlusion. I have posterior separation. It's only the anterior contact that is there on a deprogrammer. But when it comes to a splint, it has posterior occlusion as a static occlusion, anterior occlusion as your dynamic anterior guidance, along with the canine guidance in the laterotursal movements, which is known as mutually protected occlusion. So a deprogrammer is more of diagnostic thing, whereas a splint is more of therapeutic thing. It is decreasing the symptoms of the patient, decreasing the pain of the patient, and telling us, okay, you can proceed with the other modes of treatment now, which are more of irreversible in nature, more of permanent in condition. That's how we need to decide from this diagnostic mounting that how to proceed with the splint. Now we'll see a case report where a splint is given, delivered to the patient, and how the patient recovered from these things. So coming to why the patient came to me, the patient was very young. He was around 24 years, and patient unintentionally was doing certain kind of movements when it came to the mandible. So always whenever he was working at home or in the office, he used to do this minor play of the mandible. Even his father noticed it, and they decided to go to one of the colleagues, one of the dentists, and they got the treatment done probably 3-4 years back. The patient is on certain kind of appliance already when he came to me. So patient complains, though I am wearing the appliance, this habit is not going. I am not feeling any kind of change when it comes to the appliance or when it comes to the habit. So when I took the history, I didn't find any kind of anxiety issues with the patient. So the first thing when I noticed some kind of parafunctioning happening inside the oral cavity, I ask the parents of the patient or whoever comes with the patient if the patient has any anxiety issues. Then I take the history from the patient as well if the patient has any anxiety issues in the absence of the relatives or the parents. Once the patient tells me that there is no kind of anxiety or issues that is happening, I kind of rule out. It's not that I rule out completely. Probably I can rule out what is known as the nocturnal bruxism, which is more of psychosomatic in nature. It's brain mediated bruxism. Whereas usually the diurnal bruxism that happens is because of interference. So when there is some kind of interference inside the oral cavity, usually we see diurnal bruxism happening inside the oral cavity. It could be a combination of diurnal and nocturnal also, but usually we see a diurnal bruxism happening. So that's because of interference. It's tooth related bruxism. But when it is more of nocturnal bruxism, when it is more of night bruxism happening inside the oral cavity, usually it is psychosomatic in nature. It is brain mediated. It overrides the parasympathetic nervous system, and muscle does not have any hold at that time. It's the brain that has a hold on the movements that happens inside the oral cavity. So such kind of patients need to be treated separately. It has to be a combination of counseling. It has to be a combination of the interference. It has to be a combination of splint therapy. So the approach becomes different when it comes to nocturnal bruxism. But here, what patient was complaining to me was diurnal bruxism, more of daytime bruxism that was happening inside the oral cavity. So patient complains of grinding teeth during daytime when he works in the office for the past 5 years. He has been using an appliance since long and there is no improvement. Though it acted as a placebo in the initial periods of time, and patient told me that, okay, I was quite fine for a certain period of months, but later on it again started appearing inside. He does not complain of any pain, though he says now and then I get back pain here and there, and it's not continuous. So I do not take it as a major complaint of pain here. No other complaint and no history of anxiety over any issue. This is one important point which we need to record in the history when it comes to the bruxism. And how did the appliance look like when he was wearing? It looked something like this. So this was more of a soft splint which was given inside the oral cavity. So one thing what we need to remember here, a soft appliance will not help in any way in one single statement, because a soft splint is prepared in maximum intercuspation. What we do in soft splint, we make an impression, we pour a cast, we give it to the lab. They give a thermoplastic resin sheet which is printed over the cast and give it to us. What we tell the patient, you wear it inside the oral cavity and continue. What is exactly happening here? I am not changing the maximum intercuspation into centric relation. In simple words, I'm just giving one appliance which is an addition to what is present inside an oral cavity, inside the oral cavity. So whatever patient is doing inside is just happening in maximum intercuspation again. I have not guided the jaw into centric. I have not taken any record. I have not taken phase bow. I have not mounted on a semi-adjustable articulated. I have not prepared anything. It's just one cast over which one splint is prepared, that to a soft splint, a resilient splint, and then it is given inside the oral cavity. So nothing is changing as such when it comes to the stomatognathic system balance. So what we need to change here, we need to change the soft splint into a hard splint, a resilient splint into a non-resilient splint. We need to give a hard stop inside the oral cavity. We need to create a balance inside the oral cavity or the stomatognathic system by giving a centric relation record. So all these things we should plan and then give a splint occlusal appliance inside the oral cavity so that the patient recovers from the interference which is present inside the oral cavity. So what I did here, so this I've already explained that the splint is given in maximum intercuspation. So nothing is being changed as such. So what could be happening inside the oral cavity now? Now there are two things that might happen inside the oral cavity when he came to me. One is maximum intercuspation is not equal to centric relation, or maximum intercuspation might be equal to centric relation. I don't know. I can't just peep inside the oral cavity and see whether this is equal to this. I have to do a diagnostic mounting and find out whether this is equal to this or there is an interference. So what I do what is known as diagnostic mounting of the casts. For diagnostic mounting, as I already explained, I need a phase bow record, I need deprogramming, I need centric record, I need to mount the casts in these records with the help of these records. So in case the maximum intercuspation is not equal to centric relation, what could be the reason? The only reason is interference. That's it. You have an interference in the oral cavity. That's why your MI is not equal to CR. We need to make sure that the interference is taken away, relax the lateral pterygoid, and then get the joint back into centric relation. That's the whole intention of stomatognathic equilibration. This is usually nocturnal in nature if the maximum intercuspation is equal to centric relation, but still patient finds that parafunction. If it is not equal, then we can probably give a diagnosis as diurnal bruxism or a combination of diurnal and nocturnal. But if it is purely nocturnal, it is usually brain mediated more than interference mediated inside the oral cavity. So a psychologically mediated bruxism is more damaging than your interference mediated bruxism that happens. So what has to be done if the interference is there? We need to make sure that the interference is taken away. So there are two methods for it. One method is to deprogram, separate the posterior teeth by certain distance, deprogramming. And the other method is permanent and irreversible in the form of selective grinding, in the form of prostho, in the form of ortho, or in the form of surgery, as I've been explaining in the previous slides. So let's see how the separation of posterior teeth is done in this case per se. First, I gave a deprogrammer. I made sure that the lateral pterygoid is relaxed. I took a centric record. I did a diagnostic mounting. Then I prepared an occlusal appliance, which is known as stabilization splint, gave it inside the patient. And how the patient recovered, I'll be explaining. So let's come to the case per se. OPG was already present with the patient, and there was no periapical, periodontal, nor TMJ changes that are seen in the patient. The first test I do is load test. Rocabado map of pain 7, I do it. And if it is negative, I carry on with the muscle of mastication examination as well. The three muscles which I consider when I do a muscle of mastication examination, the first one is your masseter, the second one is your lateral pterygoid, and the third one is your temporalis, and the back group of muscles. Usually medial pterygoid, I avoid doing it because it is an internal muscle. It usually gives you false positive results. So I avoid doing a medial pterygoid examination. I do the masseter examination, lateral pterygoid examination, temporalis, and the back group of muscles as an examination when it comes to muscle of mastication examination. So here the lateral pterygoid and the middle fibers of temporalis were slightly tender, yes, and the back group muscle was also slightly tender. So I could provisionally get something that load test is negative, the immobilization test was partially positive, and the muscles are tender slightly. So let's see and catch the first point of contact, what is happening inside the oral cavity as an interference now. The main advantage of making a maxillary stabilization splint or a mandibular stabilization splint is When it comes to the maxilla, you have more coverage. When it comes to mandible, you have less coverage. That is one advantage. The second advantage is when you are giving a maxillary stabilization splint, the lower anterior is falling on a flat platform. When it comes to the maxilla, if I'm giving a mandibular occlusal appliance or a stabilization splint, the maxillary anterior is flared up. So whenever the maxilla falls on the mandibular occlusion, it is not in a straight flat plane that happens with the maxillary stabilization splint. So you are getting a flat plane with a maxillary stabilization splint, and the lower incisors are falling perpendicular to that plane. And it has a freedom of movement either anteriorly or posteriorly or towards the sides in mutually protected occlusion. So these are the advantages of making a maxillary stabilization splint over a mandibular stabilization splint. But if patient is socially active, if patient has any phonetic issues, then we tend to give a mandibular occlusal appliance therapy as well. We should know the difference between the maxillary and the mandibular splints. That's the difference between the maxillary and the mandibular splints. In this case, the patient was not having any problem with maxillary splint. So I went ahead with and gave a maxillary stabilization splint instead of a mandibular. So this is the first picture I saw in maximum intercuspation. Right side and left side. This looks quite okay to me. When I took the pictures in maximum intercuspation from the front, from the side, it looked quite okay. I cannot see anything here, what is happening inside the oral cavity. Now coming to the anterior guidance, you can all see that there is posterior contact in edge-to-edge position as well. So there is a lot of posterior friction that is happening on both the sides when the mandible is coming forward. I don't see any posterior disclusion that is happening here. When it comes to the right canine, there is a canine guidance loss. So I can see a group function here. I can see a group function here again. When it comes to the left, again, there is a canine guidance loss, and I can see group function crossover and then group function here. So these are probably giving me an idea that there is some kind of problem definitely happening inside the oral cavity, because of which the patient is having this kind of diurnal bruxism and slight pain in the masticatory system when it comes to the muscles. So I take an occlusal pick, and I don't see, fortunately, more of posterior tooth wear here. There is no occlusal wear facets that I've seen here, but only one thing what I've noticed is the canine is attrited here on the mesial slope. So my mind and my vision is on the canine now, because there is some kind of problem happening over the canine. Let's see by diagnostic mounting what I can achieve. So I took a phasebow record, I took the casts, I deprogrammed, I took centric interocclusal records, mounted it in centric. Then I removed the centric, I set the HCG at around 30 degrees here in the patient by taking the protrusive records. And then I dropped the maxillary onto the mandibular cast. When I dropped the maxillary onto the mandibular cast, I found some kind of contact somewhere, so that the posterior teeth are away from each other. If you see here in centric, there is no contact, there is no maximum intercuspation happening. So it simply means that the centric relation is not equal to maximum intercuspation. There is one contact somewhere that is actually lifting the other teeth away from each other in centric relation. Now let's find out that first point of contact. So I put an articulating silk in between the two casts. I tap, 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 then I see this. Typically what I saw in the picture. So there was canine slope attrition, which I saw in the picture. And if you zoom it, you will see that a typical first point of contact is still present here when it comes to the anteriors. There is no posterior contact anywhere. There is only anterior contact here, and probably on a premolar. That is actually the first point of contact acting as an interference in this case. So over a period of time, what is happening whenever the patient is going and then coming front, it's the first point of contact that is there on the canine that is causing the problem, and it is slowly going away. And that has led to a group function now, because there is loss of canine guidance because of the attrition of the slope of the canine in the anterior region. Now patient is used to this movement. Because there is loss, the mandible has been adjusted to this kind of parafunction that is happening during daytime. That's how we diagnose the first point of contact. And now my treatment plan depends on how the patient improves over a period of time by giving a stabilization splint. Probably if it's a night bruxism or a nocturnal bruxism, if I give a stabilization splint, I might see creases on the splint over a period of time. I'll see the pattern of lines that happens during nighttime. And then I can find out that the parafunction is more in intensity. So let's see if I find it or not. So what I do with this HCG and with the vertical dimension set, the vertical dimension I assessed on an articulator here by seeing the difference between the maximum intercuspation and the centric relation. I open up the centric latch, I press the upper member of the articulator down till it goes into maximum intercuspation. I find the difference between these two, and that amount of vertical dimension can be safely increased here for the fabrication of splint. So it was around 1.52 mm. So I increased the vertical dimension and then I started preparing the splint. The splint can be prepared in two ways. One is intraoral and one is extraoral. You can either use oral cavity itself as an articulator, see for the dynamic movements, see for the static movements, and then prepare. The only advantage of extraoral preparation is I don't encounter the lips. I don't encounter the cheek, tongue, and the saliva inside the oral cavity. So I can safely prepare an extraoral splint without these things in between. So I preferred an extraoral preparation of splint in this case. And there are two methods again. One, you can prepare a hard splint completely. One is a combination of soft splint as a base, which acts as the convenient mechanism for the patient to put in and remove it. Over it, I build up a hard splint. So probably around 1 millimeter of a soft splint as an initial drag inside the oral cavity, and then we build up acrylic over that soft splint as a hard splint so that we can give a hard stop in mutually protected occlusion in centric relation. So I took the second method here where I prepared a soft splint first, a thermoplastic resin sheet, and then over it I started building acrylic. So you can either build wax pattern, you can take wax, you can build the wax, convert it into heat-cured acrylic splint, or you can make a self-cured acrylic or autopolymerizing acrylic resin splint as well when it comes to the preparation. Here I went ahead with a self-cured acrylic splint. What I do first is I put the soft splint or the thermoplastic resin sheet, I mix some self-cure, I add it in the anterior region in order to develop the anterior guidance. That's the first step I do. So I mix some soft cure, self-cure, and then I place it in the anterior region. I open up my centric latches and then I program in such a way that I get anterior guidance. So this is your incisive ramp, which gives you incisal guidance. This is your canine ramp, building ramp, which gives you canine guidance in the lateral torso movements. So first I program that. First I fabricate that anterior section. Once the anterior section is ready, till I achieve good amount of posterior disclusion, then I add up posterior acrylic as well. Now posterior acrylic is added to get a static occlusal stop in centric relation. So what I'm achieving now in centric relation, I'm getting a static occlusion and a dynamic occlusion in mutually protected occlusion scheme by giving anterior guidance, by giving canine guidance, and by giving static occlusal stop, opening and closing. See this picture, you'll understand that in anterior guidance, you have posterior disclusion here. This is all done on a semi-adjustable articulator before we carry it inside the oral cavity. Posterior stops are single point stops, which we fabricate, which we create on the splint. I don't want acrylic to flow here. I don't want acrylic to flow here in between teeth. So once the posterior acrylic is spread over the splint and you get the posterior stops, you take a burr and remove all this excess in between the teeth. Here, 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 here. I need only the functional cusp stops over the platform in the posterior area. Only point contacts. Rest of all the acrylic is removed and polished, so that when patient bites on, the patient's posterior teeth will have only functional cusp to the platform contacts. I don't have any other hindrance anywhere, so that the mandible can move anteriorly, posteriorly, side to side freely without any restriction inside the oral cavity. So if you see here also, we have only point contacts of the functional cusps. We don't have any extensions in between the teeth that act as your hindrance mechanism for the movements to happen. I need posterior immediate disclusion. If I want immediate disclusion, I don't want these extensions behind in the anterior ramp. So that's how we design a splint, so that we have an anterior incisive ramp, canine guiding ramp, and the posterior platform with only static functional cusp contacts, no other contacts on the splint. You can see here in canine guidance, your posterior disclusion. In canine guidance, your posterior disclusion. On the other side, also, you should not have any contact on the splint when the mandible is going side to side in late protrusive movements. So when it comes to the final result, you see something like this. You have dots in the back and lines in the front that is guiding the whole stomatognathic system forwards. I don't see any lines at the back. If you see, there are only functional cusp contacts that are falling as the dots. And there are dots in the anterior as well, minimum intensity dots. From there, you have anterior guidance and the canine guidance that is given in the splint as your mutually protected occlusion scheme. So now the splint is carried on inside the oral cavity. We check for the static movements, we check for the dynamic movements. If you have any minor corrections, you can do it inside the oral cavity. Usually, if you have followed all the procedures in a protocol, you would not find any major difference between the oral cavity and the articulator preparation of the splint. Now, if you see in static, you have good occlusion. In anterior guidance, you have posterior disclusion. And in canine guidance, you have posterior disclusion on the other side also. If you have any minor contacts here and there, you can take a burr and eliminate those minor contacts. So this is known as programming of a splint intraorally by preparing the splint extraorally on a semi-adjustable articulator. Becomes an easy procedure for us to do, and becomes an easy procedure for the patient also to accept the splint, rather than sitting inside the oral cavity and doing it, which becomes a cumbersome and sometimes a messy procedure. So this is how you check. Finally, inside the oral cavity also, I again check with occlusal indicator, dots at the back and lines in the front. It should be the same as I see it inside a semi-adjustable articulator. Coming to the extensions of the splint, we don't need extensions onto the soft tissue. It is only on the hard tissue, and you can eliminate half of the portion of the splint over the teeth. It can be extended only till the labial half. The incisal half can be covered and the cervical half can be eliminated. You need not proceed on to the gums. You do not place it on the gingival tissues. And make sure that the splint is smooth and polished well before we give it to the patient. Recall the patient is very important when it comes to stabilization splint, because if you don't recall the patient, you will have something called as jumping contacts. I give a stabilization splint and send the patient back. After a few days, the centric might not be the same. The jaw might actually shift back a little, and now you will see an anterior open bite in the splint in most of the cases. So recalling the patient at regular intervals to see what is happening is very important. So when do I recall? Usually I recall 48 hours, 1 week, 15 days, and a month to see if the splint is doing well, number one. and to see if there is an anterior open bite that has crept in after I delivered the splint to the patient. Because the centric, I don't know if the centric is same or it has changed again. So that is why recalling the patient is very important. And the patient came back to me probably after 2 months after these recalls and revisits. And after 2 months, the patient has stopped finally doing the movements. And then we proceeded according to the rule of thirds to take this case for orthodontic treatment. Orthodontic stabilization has been done for the patient. And post orthodontic stabilization, I again did diagnostic mounting to see if there are any interferences again. This is one important step which I do in my clinical protocol to do a diagnostic mounting post orthodontic treatment as well. Most of the times, if we do this diagnostic mounting post orthodontic treatment and equilibrate again in the form of minor interferences, relapse of the case is taken care of. That is one important point which I usually do it or sincerely practice in my practice, post orthodontic equilibration. So now the patient is doing fine and the ortho has been completed. This is a picture. If you see here, there is an anterior open bite that has crept in after probably 10 days. So what we do in such case, again, we close the anterior open bite. We again make sure that the posterior contacts are stable in centric relation. And we also make sure that the anterior guidance and the canine guidance are taken care of when it comes to the ramps. So this is how we need to see if there is any anterior open bite that has crept in inside the patient's oral cavity finally. Okay, so I'll show two brief videos where the check is done on an articulator, the check is done inside the oral cavity as well. So if you see this video, this is done on a semi-adjustable articulator where you can check the anterior guidance, canine guidance and posterior stops together. So this is your anterior guidance giving you posterior disclusion on a splint in mutually protected occlusion. So this is the posterior disclusion that is happening. Coming to the canine guidance, you should see that there is posterior disclusion again. No interference on the working side as well as on the balancing side. Coming to the other side, canine guidance, again, you make sure that there is no contact on the working side and no interference on the balancing side. And finally, you should have anterior and posterior stops without any extensions in between the teeth. That is important. So finally, you get dots at the back and lines at the front. Okay, so now we'll go to the other video and I'll show you how to actually check it inside the oral cavity. So whatever you saw outside the oral cavity has to be present inside the oral cavity also when the patient is doing the static as well as dynamic anterior and laterotrusive movements. You should have all point contacts, no extensions in between the teeth when it comes to the posteriors. That is more important to check in the posterior region than when it comes to the anterior region. So I hope this presentation was helpful. I hope this presentation was informative. And this is how I proceed with my procedure of making an occlusal appliance therapy to stabilize the masticatory system or the stomatognathic system in the form of a stabilization splint. Thank you, everyone.
Mahidha, you have a lot of questions.
Yes, sir. I'll go through.
Just have a look and answer. And for all the attendees, I just would like to inform you that we are going to post this link of this video on JSS website. And maybe if I get permissions, I may post it in IPS Karnataka website also. Okay, now Mahidhar, on to you and the
Yes, sir.
panelist. Please take care. I'll be listening. Start with
Dr. Mahi, it was an amazing presentation.
Thank you, sir. Thank you.
The details that you have provided in your presentation is excellent, especially for the postgraduates as to how to fabricate a splint, how to mount a do a diagnostic mounting, how to assess for the first point of contact, and how to equilibrate your splint on the articulator and then on the in the mouth. It was an excellent presentation, and they needed to know this in detail. And actually, we are very, very thankful as academicians that you have put in this effort to show these kind of videos and slides to help our students get an insight on this. We can take up the questions if the if the other panelists have got anything else to add.
Dr. Sanath, Dr. Sanath, I think Dr. is waiting to come. First, ask Patel sir to give his comments before we go into the question and answers.
It was really excellent presentation, very informative, valuable.
Thank you, sir.
Evidence is Dr. Mahindra. Excellent, really. I also came to know a few tips I got from your presentation.
Thank you, sir. Thank you so much.
Not only for PG students, but for the practitioner also, the technique whatever we have shown.
Sir, your voice is breaking, sir.
Different type of things whatever he has shown, even that combination of soft as well as hard, these all are really useful to all PG schools as well as for practitioners. Really good start for your webinar series, Dr. Anil, Dr. Singh. Again, I congratulate to the whole team for right selection of topic as well as speakers. It was really excellent presentation.
Thank you, sir.
Again,
thank you so much.
My best wishes to you. Thank you.
Thank you, sir. Glad.
Sir, thank you on behalf of JSS. Thank you very much for giving us this opportunity, sir. And it was very nice to see you attending the lecture continuously.
My pleasure. My pleasure.
Thank you, sir.
I listened each and every word presented by Mahir.
Thank you,
really,
sir.
because I also do practice, and I also have prepared splints for many patients, but few more newer techniques I have learned from Dr. Mahir. Thank you.
Thank you, sir. Thank you.
Go ahead with other questions.
Yes.
Dr. Rupesh, do you want to say anything, or can he go to the question and answers? We'll proceed, Mahidhar.
Yes, sir. First question by Dr. Divya Goel. I did not understand the difference between true TMJ and intracapsular disorder. Load and stabilization test are negative in which case? Dr. Divya, the true TMJ and intracapsular disorder both are the same. So it is not different when it comes to the explanation. When it comes to extracapsular, it is different from your true TMJ disorder. True TMJ disorder is something which is present inside the TMJ, and extracapsular is something which is present outside the TMJ. The load test and stabilization test are negative, in which case, in many cases, need not be positive when it comes to the load, need not be positive when it comes to the stabilization test. If it is positive, we need to take a protocol. If it is negative, there is no need to bother. We can proceed with the deprogramming. Should we remove the interference first or correct the TMD? It always has to be the TMG first. If you talk about TMD, I would not say TMD as the true TMJ problem as such. TMDs can be extracapsular, TMDs can be intracapsular. If you have an intracapsular disorder, target it first, treat it first, and then comes to extracapsular. That's what is the order that is usually followed. So we cannot generalize TMD as such. You can tell it as intracapsular disorder can be corrected first, and then we can come to the interference. What occlusal scheme to give an NFMR, group function or mutually protected? It depends on, again, the conditions. If you have probably an implant, which is there as a full mouth case, in implant full mouth cases, we don't give canine guided occlusal scheme. We go for a shallow group function. When it comes to natural teeth or FPDs as full mouth rehab cases, then if the canine is periodontally strong, then we target what is known as your canine guidance in mutually protected occlusion. Please do not classify it as group function or mutually protected. Mutually protected has either canine or group function as laterotrusive movements in the scheme. So it cannot be a different thing when it comes to group function and mutually protected. You can say it as canine guided or group function when it comes to the laterotrusive movements. Dr. Siddharth, deprogramming is done for how long? I, in my practice, do deprogramming at least for a week. Sometimes probably till 10 days as well. So I need some time for the lateral pterygoid to deprogram well before I proceed to capture the centric relation record. So that's what I follow as a protocol in my practice. Dr. Asmita, when there is an interference, we have to remove that interference. Then how a splint with increased dimension help the patient? If you are giving a splint in centric relation, in simple words, it means that you have removed the interference. Because interference is present in maximum intercuspation. The moment you change that into centric relation, you are eliminating the interference by default. So giving a splint is nothing but removing the interference by introducing a platform in between the maxillary and the mandibular arches. Please upload the lecture in Facebook. Okay, that's a different thing. I hope how to fabricate a stabilization splint is answered as the final section. Upload the lectures. Dr. Vinuta, good afternoon. Does deprogramming have to be done for 2 weeks for every patient? No, you can recall. You can recall the patient after 48 hours and see. You can recall the patient after 1 week and see. According to the symptomatic increase or decrease inside the patient's stomatognathic system, we take a call. Sometimes if there is no problem at all, we use Lucia Jake to deprogram the mandible chair side also. So there is a chair side deprogramming also that is done. There is a 48-hour deprogramming, 1 week and 10 days deprogramming. So according to...
Mahidhar, 1 second, sorry for interruption. Maybe the panelists, if they want to say anything, just we need to ask them.
Sure, sir, sure.
Now first check with the panelists if they want to ask anything, number 1. And number 2, Mahidhar, small other questions which can be ignored like videos, uploading and all, you can just ignore. Because
yes,
it's already late.
Yes, yes. So over to the panelists.
Yeah, Mahidhar, wonderful presentation in solving the complex problem of TMD and how to stabilize them with the occlusal appliances. My compliments to you. I think it was a very easy manner conveyed to all the participants, except for few small clarifications here and there. I don't think so. There should have been any doubts being raised here. I think that is my take on your presentation.
Okay, sir. Thank you. Thank you so much.
Dr. Manoj,
balanced occlusion is something which we incorporate in removable processes. So when it comes to the fixed dentition, we usually don't incorporate balanced occlusion either in full mouth rehab cases or in implant occlusions or in FPD cases. But if you have a combination of fixed versus removable, yes, we take the removable into consideration and we incorporate balanced occlusion inside the oral cavity just to make sure that the stability of the removable process is taken care of with the incorporation of balanced occlusion. Otherwise, balanced occlusion is not something which we talk about when it comes to the fixed dentition or your natural dentition, only for the removable processes. Dr. Reshma, what is the ideal amount of disclusion in posterior and lateral excursion and why? There is no ideal amount of disclusion. There should not be any interference of the posterior teeth when it comes to the anterior as well as lateral movements. As long as there is no friction that is happening, there is no contact that is happening in between the teeth, the stomatognathic system is in a kind of equilibration or a balance. CCP is the reverse pattern of chewing. What we chew is like a cow. We take the mandible back and come front. In CCP, which is constricted chewing pattern, we come front and then we go back. So there are equal chances of distalizing the mandible back and the condyle going on to the retrodiscal tissue, damaging the tissue. So in such cases, we usually prefer a Coase deprogrammer to deprogram the lateral pterygoid muscle. How long should we continue the splint therapy? I usually continue the splint therapy for 2 months, at least 1.5 to 2 months. See the symptomatic relief for the patient when it comes to the pain. When it comes to checking the splint therapy vertical dimension, I continue it for 1 month and then take a call according to the adaptation that happens in the stomatognathic system and the convenience or comfort zone of the patient. So the splint therapy is not only used for the pain or any other symptoms, it is also used to assess the vertical dimension sometimes. If you have flat occlusion inside the oral cavity, completely worn out dentition, then we give splints, stabilization splints, and also assess the vertical dimension increase sometimes, whether the patient is getting adapted to the present vertical dimension or not. So in such cases, I go for 1.5 months. Otherwise, I look out for the symptomatic relief and then proceed with the irreversible mode of treatment modalities. We should, what should we do if we develop anterior open bite after splints? You have to again add up acrylic in the anterior open bite, check for the posterior contacts in the static occlusion, and then equilibrate again inside the oral cavity so that you have dots at the back and lines in the front. Dr. Kalyana Srinivas, I think I've answered your question about the deprogrammer.
Dr. Mahi, can we slightly go fast, because I think we are already going past the 1 o'clock mark and it has been a very long session. Just to raise one pertinent point, how do we decide on whether the splint has to be a maxillary one or a mandibular one? I think probably that is a question that everyone wants to be answered.
So the maxillary occlusal appliance therapy is the best preferred when it comes to the literature, because we are getting a flat contact on the platform. But when it comes to the mandibular occlusal appliance therapy, it is more convenient to the patient when it comes to the social mingling with the others, or when it comes to the phonetic aspect. So as long as that is not a problem, I would prefer a maxillary occlusal appliance therapy to the patients, maximum number of patients. So I take that as a consideration when it comes to maxillary versus mandibular. The coverage is more in the maxillary, the stability of splint is more in the maxillary, and the contact which we have with the mandibular incisors is flat. But when it comes to the mandibular occlusal appliance, when you have maxillary teeth which are protruded, that is reverse of what we are achieving when it comes to the maxillary occlusal appliance therapy.
Dr. Mai, do you want to add anything on anterior repositioning splint?
Mahidhar, Divya Vashist has a question.
Sir, I missed it.
When pain is on a unilateral side near the ear, and that too just on clenching, what do you do?
So I do the load test first. Whichever pain, whether it is unilateral, whether it is bilateral, the first test I do would be a load test. I probably get an idea if the load test is positive or negative. If the load test is positive, I send the patient for an MRI immediately, because I want to rule out the intracapsular pathology as the first step here. Once that is ruled out, then I can go ahead with stabilization splint.
And the next question is, how do we proceed in class 2 situations?
So in class 2s, I would go with probably a Coase deprogrammer, deprogram it, get the symptoms relieved, and probably take a call with an orthodontist if the ortho correction can be done to get a stabilization inside the masticatory system or stomatognathic system after the diagnostic mounting. And coming to the anterior repositioning splint, Dr. Sanats, We usually give anterior repositioning splint when we have disc displacement with reduction. So suppose the disc is anteriorly displaced and it is the condyle is getting reduced below the disc, then we find that anterior position which is very comfortable so that the click is disappearing, and then we fabricate an anterior repositioning appliance in that position. So it is an intracapsular disorder that needs to be considered, which is away from the extracapsular disorders which we discussed today.
Also, anterior repositioning devices can be given when there is inflammation of the retrodiscal tissue,
yes, perfect.
so that you can relieve the tissues by positioning the condyle in an anterior position. So
Yes.
since that was not taken up in, I just wanted you to give some insight on that. That's all.
Any retrodiscitis, we can go ahead with anterior repositioning splint so that the healing is done and the inflammation comes down.
Yes.
Anyone else? Mahidhar, thank you for keeping up my name. You haven't disappointed me.
Thank you, sir. Glad to hear that.
And all the best. I think now Dr. Sunil would like to say a vote of thanks. Dr. Sunil?
Yes, sir. Yeah, first of all, as we end today's event, I would like to thank all of you for joining the webinar series. And today we have received a huge number of registrations, which shows that there's a strong commitment to our profession and the starting of the webinar series and the urge to have this sort of improvement during such situations. My heartful thanks to our President, Dr. J.R. Patel, sir, Dr. Rupesh, the Secretary of the IPS, for their support and encouragement and being here throughout the webinar series. Thank you very much, sir. In particular, I would like to thank Dr. Anil for taking up this initiative, sir, and the JSS Academy for their support, and the entire organizing team and the IT support which they have provided. Thank you very much, sir, for making this program a success. Thank you.
Thank you, everyone.
Thank you, one and all. Thank you, Dr. Mahi.
Thank you, sir.
First, I would like to say thanks to Dr. Patel, sir, for being there, and Dr. Rupesh and Dr. Sunil, and of course, Mahidhar, I should, and I don't know if I should also.
No, sir.
but I need to officially thank the IT team of JSS University, which made this possible, especially Dr. Sumuk. He happens to be our student and son of our IT head. He has gone through a lot of work. I had been troubling him, pestering him, and doing what not to him to do this. I also would like to thank the JSS University for giving us the licensed version for this. And let's hope we all meet again, because the next webinar will be on, tentatively I have put it up as ergonomics. And then I'm going back with Mahidhar. I think you said you're ready with bonded restorations, right?
Yes, yes, sir.
So
yes.
Maybe after the ergonomics, Mahidhar will be back with us talking about bonded restorations. The time and the thing, I'm not sure. I'll check with Patel sir and whatever they advise, whether we need to go weekly basis or fortnight or monthly. That we will decide and let all of you know. In the meantime, if all of you can send your emails, it will be kept in the university website, and any information about our future webinars will be sent to you by the IT team. Thank you one and all. Thank you, Dr. Sunil. Thank you, Mahidhar. Sir, thank you, sir.
All the best. Stay safe and stay active. All the best once again.
It's feeling like we are leaving a home. Good. Thank you, sir.
Thank you, one and all.